just to give you a little background, opioids are some of the most frequently prescribed medications in the world. I don't think that's any surprise to anybody here. More people died of drug overdose in 2014 than any year on record. That's because the numbers are increasing. The majority of these, over 60%, involve opioids. The rate of overdose deaths involving opioids has nearly quadrupled since 1999. 165,000 people on record. In 2012, healthcare providers wrote 259 million prescriptions for opioid pain relievers. That's enough for every single American adult to have a big bottle of pills. That's a ton of medications. Almost 2 million Americans aged 12 or older either abused or were dependent on opioid pain relievers in 2013. There's been a 300% increase since 1999 in the prescription opioid sales, but there's not really been an overall change in the amount of pain people are reporting. So what does that tell you? In 2013, more than 16,000 people died from overdoses related to opioid pain relievers, which is, again, 4 times it was in 1999. If you look at this, whatever you want to call it, map, it shows the number of painkillers prescribed per 100 people. Let's see here. If you look here, seems like in the South, a lot of people, 96 to 143 per 100 people, whereas a little more in the North, it's more like 52 to 71, which is lower. It doesn't always correlate with deaths. If you look at Colorado here, let's look at California and Colorado. They're both on the low side of prescription drugs, but then if you go to the age-adjusted drug poisoning deaths in 2012, Colorado is actually higher than the average, whereas California is still really low with rate of deaths, poisoning deaths. So again, it doesn't always correlate, but those are the numbers. As far as the national overdose deaths, if you look at the rates over the years, starting in 2001 to 2014, you just look at the overall numbers here, and up here it's well over double. So there's a ton of people dying from opioid overdoses. If you look here, drug overdose deaths by major drug type from 1999 to 2010, you can see that opioids are by far the leading cause. Well above cocaine, heroin down here, and what's the great one? Benzodiazepines. So they eclipse all the other ones combined, basically. So this is the number of deaths in Colorado in 1999, and here it is in 2014. These are opioid deaths. So you can see it's rapidly increasing. Maybe it'll fall off now that pot's legal. Not as many people use opioids. I don't know. It's a possibility. Same thing, death rate per 100,000 by gender. If you look here at 1999, opioids and then heroin. It's interesting, opioids are about equivalent in males and females, so females is the green and males is the yellow here. But then if you look at heroin, males are used like 5 times as much as females. Interesting. So if you look at up through the trend from 1999 up to 2014, as you can see, across the board it's pretty much increasing. So interestingly enough, this is a study or a comment. I think this was in the New England Journal, one of the next one is, but they looked at 39,000, almost 40,000 patients, and about 12,000 of those had received at least one narcotic prescription. And basically they looked at the incidence of addiction, which was only 4 in all those 12,000 patients. This is back in, what was the year on this? A long time ago, back in the 80s, I think. Anyway, their conclusion was that despite widespread use of narcotic drugs in hospitals, the development of addiction is rare in medical patients with no history of addiction. That's changed dramatically over the years. Now, there's a huge shift. But if you look at what a recent paper, Reducing the Risks of Relief, the CDC opioid prescribing guideline, the science of opioids for chronic pain is clear. For the vast majority of patients, the known serious and too often fatal risks far outweigh unproven and transient benefits. Meaning, the bad part of the opioids are far exceeding the good part, pain relief in the patients with chronic pain. So, some people refer to pain as the fifth vital sign. It's not always really easy to tell somebody's in pain. Sometimes you just have to look at them really closely. And I don't know if he's on drugs or if he's just in pain. I don't know, or both. So this is what we really want Eric to look like, this guy right here. So the opioid manufacturers continue to advertise opioids as safe and effective for chronic pain. As you can see, you go from this to this, break out of pain with Vicodin ES. Kind of silly. So what about opioids for chronic pain? There's a serious lack of long-term studies evaluating benefits versus risks in the management of chronic pain. The evidence for chronic pain on the studies that we do have are uncontrolled, and in general, there's just no proven benefit. This was a review in the Annals of Internal Medicine, the effectiveness and risks of long-term opioid therapy for chronic pain, a systematic review for National Institutes of Health Pathway and Prevention Workshop. Their conclusion, as you can see down here, evidence is insufficient to determine the effectiveness of long-term opioid therapy for improving chronic pain and function. Evidence supports a dose-dependent risk for serious harm. So, with that background, getting to our study, the objective of this study was to assess the relationship between the preoperative use of analgesic opioid medications and clinical outcomes for patients undergoing TLIF, that's transforaminal lumbar antibody fusion. That's just the most common lumbar fusion we do for degenerative low back conditions. It was a prospective observational study. So we didn't randomize people to receive opioids, before having surgery or not. When they came in, they were either on them or they weren't. So a total of 93 patients. None of them had had previous surgeries. They were all 1 and 2 level lumbar fusions. There were 15 patients lost to follow-up. We took the daily opioid use and converted it into what we call a standard morphine equivalent dose. So looking at the basic demographics and surgical characteristics, there's not really any statistically significant differences of age and female to male. There was some difference in the duration of symptoms, with the patients, the non-users having longer actually, and everything else was pretty similar, including operative time and all that stuff. So if you look at the numbers, again, before the preoperative visual analog scale for the patients, there were 60 of them that were using opioids before surgery, and there were 33 that were not using them. They were all about similar. The Oswestry Disability Index, there was a statistically significant difference preoperatively, and that the patients on the opioids had a higher Oswestry Disability Index than the ones that were not on opioids, which is not surprising. And then the SF-36 physical component score was not statistically significant, but the mental component score was. So, what about the postoperative clinical outcome scores? Now we get into statistical significance, so the visual analog scale. What is that noise? He's playing videos over there?
He's watching a movie.
Okay, so With the opioid users, it was 2.5. They had a higher visual analog scale postoperatively than the non-users. So in other words, they did worse. That was statistically significant. Same thing with the visual analog scale, leg pain, Oswestry Disability Index higher. Again, with the opioid users, now they were higher to begin with, but this was statistically significant change. And then the physical mental component scores was statistically significant with the physical component score, not with the mental component score. So basically, what does all that tell you? The results indicate that essentially all patients improved with surgery, whether they were on narcotics or not. But the patients that did not use opioids preoperatively had significantly better outcomes at 12 months follow-up than the ones that did preoperatively. This was despite the fact that the non-users had disease symptoms twice as long and had a higher percentage of two-level surgeries. So preoperative, there are some other studies. Preoperative use is a negative predictor among patients undergoing gynecologic surgery, total knee surgery, hip arthroplasty, and prior studies, spine surgery. Again, those are retrospective studies. This is the first prospective trial. Multifactorial reasons for worse clinical outcomes. There's opioid-induced hyperalgesia. Clinical implications associated with this are difficult to really figure out. But the bottom line is use of opioid medications is a potentially modifiable risk factor going into surgery. And if the patients are not on opioids going into surgery, then they're going to do better post-operatively. So in conclusion, the use of opioid medications to control pain before lumbar fusions or degenerative conditions was associated with less favorable outcome post-operatively. This is the first study that has demonstrated this association in a homogeneous cohort of patients undergoing lumbar fusions, this type of lumbar fusions, in a prospective fashion. This just shows a paper that we recently published in the journal Neurosurgical Spine showing exactly that prediction based on preoperative opioid use as clinical outcomes after transforaminal lumbar interbody fusions. We've also already gone ahead and implemented some multimodality preventative perioperative pain management things in order to try and decrease opioid use and improve pain scores. This is one of the evidence-based guidelines that we've adopted at some of the hospitals. We give these medications preoperatively, and then we give these medications postoperatively, trying to reduce the amount of opioids.